Let me just thank you in advance for your wonderful previous talk. I think you have an astonishing organization, but what I'm quite sure is that you would have a hard work, I would say very, very hard work to reproduce that in Spain. But you can try, you can try. Okay, now you're getting into another, I think, darker field, like is the local treatment in metastatic prostate cancer, and I'm really expecting what you're going to tell us.
Yeah. Thank you very much. So my last talk will be about local treatment in the oligometastatic patient. I have no disclosures. So we will go over the following 4 facts. The evidence supporting surgery in metastatic prostate cancer is very poor. The morbidity of radical prostatectomy in these patients is increased. We have lessons to be learned from breast cancer, and we also have first data from randomized trials on radiotherapy in this setting. This is a systematic review on the topic we performed last year. It summarizes that there's no randomized data which show a survival benefit for surgical treatment of the primary, and all conclusions to date in favor of surgical treatment of the primary are gathered from observational data or retrospective institutional studies. Most of these retrospective data, as summarized here, are from the North American SEER database. Kalb and colleagues were the first ones to publish on this from the SEER database. They looked at more than 8,000 patients. This study was updated several times throughout the years, last by Leibanura et al. In 2017. All the studies published that local treatment was associated with a survival benefit. So this is the Kalb study, including patients from 2004 to 2010. 245 had radical prostatectomy, 129 brachytherapy, and the Kaplan-Meier curve shows that local treatment was associated with better outcome. As mentioned here, the Leibanura study updated these results up to 2013. And in addition to the Kalb study, they performed propensity score matched analysis and reported that both local treatment types, radical prostatectomy and radiation treatment, yielded lower cancer-specific mortality rates relative to no local treatment. What they did in addition, they performed a comparison between radical prostatectomy and radiotherapy in the SEER database, and reported that after propensity score matching, radical prostatectomy resulted in lower cancer-specific mortality. What is important to note here that all these studies based on the SEER database are reporting on 2.3% or 3% from the whole cohort. So there are other significant limitations of the SEER database. There's no information on comorbidities. Site-specific external beam radiation treatment codes are unavailable, and only brachytherapy codes were analyzed. Post-treatment PSA values and data regarding systemic therapies are unavailable. There's no information regarding the extent of metastases, no information on number or site of metastatic disease, only M substages. And interestingly, baseline PSA data were only available for data from 2010 onwards until the SEER release in April 2017. So once the baseline PSA data were available, we did another analysis on the SEER database last year and included patients up to that release in 2014. And we analyzed, first of all, the results stratified by M1 substages. In these analyses, we saw that patients with visceral metastasis don't profit from surgical treatment. Patients with bone metastasis only profit up to a certain baseline PSA. So we looked at the relationship between baseline PSA and 3-year cancer-specific mortality. And we saw that lower baseline PSA values resulted in a survival benefit when local treatment was compared to no local treatment up to a threshold of 60. Maximal survival difference between local treatment versus no local treatment was recorded in patients with bone metastases when baseline PSA was below 40. And as said, there was no survival benefit in patients with above a PSA above 60 or M1C disease. So our results emphasized that the importance of patient selection and indicated that a general survival benefit from local treatment remains highly questionable. Other than SEER database, there are plenty of retrospective data on the topic. Here summarized from the Munich Cancer Registry and Institutional Case Series. But as you see the sample size, it's talking about 11 patients or 23 patients. The highest number is 106 patients from a multi-center study, all saying that local treatment was associated with a survival benefit. But if you go into the details of the study, it's interesting that none of these performed any multivariable analysis. So selection bias is very powerful in all of these studies. There are fundamental shortcomings of methods and unknown confiners which make interpretation of these findings almost impossible. Men undergoing surgery are more likely to be fit, have a lower burden of metastatic disease, and have robust disease responses with systemic therapy. So no surprise, these do better and may have probably done well without surgery. So to overcome the issue of selection bias a little bit, we performed a 2-center study 2 years ago in cooperation with the Copenhagen Prostate Cancer Center. We compared 43 metastatic patients up to 3 bone lesions, PSA below 150, which received a radical prostatectomy in the Martini Clinic, with 40 patients from the Copenhagen Prostate Cancer Center with the same tumor characteristics, but who did not receive any local treatment. And why we chose the Copenhagen Prostate Cancer Center is because this center never performed local treatment, no matter how small the metastasis was. So we tried to minimize selection bias. So when we look at the characteristics of the 84 patients included, we saw that patients who did not receive radical prostatectomy, the patients from Copenhagen, they had worse tumor characteristics, higher number of bone mets, higher CT stage, higher biopsy Gleason. But despite being different, there was no difference in castration-resistant free or overall survival in the patients receiving radical prostatectomy versus no radical prostatectomy. And even in the multivariable analysis, we did not see a benefit for patients receiving radical prostatectomy. Similar data from a California registry published in 2018 in Cancer by Delera and colleagues. They showed no difference in prostate cancer-specific survival between conservative management versus aggressive treatment, meaning with local treatment, after adjusting for covariables for men with metastatic disease. So second, the morbidity of treatment is clearly increased. We showed this in a study last year using the National Inpatient Sample Database, which includes 20% of US inpatient hospitalizations. So we saw that patients with metastatic disease undergoing radical prostatectomy had higher overall complications clearly than radical prostatectomy in patients with localized disease. We have important lessons to be learned from breast cancer. So about 10 years ago, we had a similar situation in breast cancer where there were plenty of studies claiming that surgery in patients with metastatic prostate cancer was associated with better overall survival. But 10 years later, when results from randomized trials came in, it was seen that there was no difference in surgery versus no surgery in overall survival in metastatic breast cancer patients. So I want to cite this nice editorial, which was published in the JCO last year. It was actually on bladder cancer, but in the editorial, the author stated that this is easily applicable also for prostate cancer. And the title was that there are potentially dangerous findings from observational data, such as the SEER database. And the authors said the risks of getting this wrong are substantial. The oncology community will be doing a tremendous disservice to our patients if we generate data that are used to justify major surgical procedures with significant morbidity and no real benefit in patients with terminal cancer. And similar to this, there was a really interesting study this year published in JCO by Sony and colleagues. And what the authors did is they searched Medline for observational studies comparing 2 treatment regimens for any diagnosis of cancer, for example, using the SEER or National Cancer Database. And then they looked for randomized trials comparing the same treatment regimens as the observational studies. So primary outcome of the study was correlation between survival hazard ratio estimates provided by the observational studies in comparison to the randomized trials. The authors found 350 treatment comparison, and these were matched to 121 randomized trials. And what they found is no agreement beyond what is expected by chance, regardless of reporting quality or statistical rigor of the observational study. So this is also a little bit shocking. We have first data from 2 randomized trials available in the prostate cancer setting. First one first the HORAD trial was published from the Dutch group. 432 men with primary bone metastatic prostate cancer were randomized to ADT or ADT plus radiation to the prostate only. Primary endpoint was overall survival. There was, in this randomized trial, no significant difference in overall survival seen between patients receiving ADT or ADT plus radiation to the prostate, but one has to highlight that these patients had a very advanced disease with a median PSA of 145, and with 2/3 of the patients having more than 5 bone mets. When the authors tried to do a subgroup analysis with patients with less than 5 mets, they saw that there was a trend for better survival in the radiation group in these patients. However, the analysis was not powered for this conclusion. In contrast, the STAMPEDE trial also published their results last year on arm H, metastatic patients receiving ADT plus radiation. They published it in Lancet. Patients were randomized between 2013 and 2016, 2,061 men. And when looking at the overall patient group, overall survival was not different between patients who received radiation versus the ones who did not. But when patients were substratified by metastatic burden, there was a clear survival benefit for the patients with low burden metastatic disease receiving radiation treatment. So the authors of the study concluded that prostate radiotherapy should be a standard treatment option for men with newly diagnosed metastatic prostate cancer with a low metastatic burden. and that local treatment to the primary should be tested for patients with small volume metastatic disease from other malignancies. The stopgap radiotherapy collaboration group then published a systematic review and meta-analysis on these two trials, STAMPEDE and HORAD, and showed then when taking together and looking at patients with less than 5 bone mets, there was a survival benefit for the group which received radiation. Based on these studies, the EAU Guideline Committee changed its recommendation from 2018 to 2019. While in 2018, we said do not use castration combined with any local treatment, radiotherapy or surgery outside an investigational setting, except for symptom control. The 2019 guidelines state to offer castration combined with prostate radiotherapy to patients whose first presentation is M1 disease and who have low volume of disease by charted criteria. What about randomized trials in the surgery setting? We started this trial from the Martini Clinic in 2015, the GRAM trial. It was randomizing patients to ADT versus ADT plus radical prostatectomy. Patients were allowed if they had up to 5 bone mets and PSA at diagnosis of less than 200. We have more than 110 patients randomized, but once this STAMPEDE results were published last year, the decision was made to discontinue the study. But the patients randomized will be analyzed further. There's this ongoing study from North America, the S1802 study, randomizing patients to systemic treatment plus surgery or radiation versus systemic treatment only. And PI on the study is Brian Chapin from MD Anderson. So in conclusion, radical prostatectomy in men with metastatic prostate cancer is currently being assessed in clinical trials, but should not be considered outside of a clinical trial. And treatment of the primary tumor with radiation should be considered in men with de novo low volume metastatic disease, as radiation is associated with prolonged survival and a tolerable toxicity profile. Thanks.
So you don't need that horrible thing, right? So, in fact, this was the first plan, but I think she has much more experience than us in managing advanced and metastatic prostate cancer with local treatments. So, ¿puedes ir ahora a la 47, por favor? So we jump my presentation, and which is very close to her, and we come one more, una más. This is this year meeting it was not in St. Gallen, it was in Switzerland, and I'd like to know if you do agree with this percentage of voting in the 4 questions related to this item. The first one was, do you think that local treatment of the primary tumor has an overall survival in? Do you agree with question 2? Right. Ya manejo yo. I guess after your talk that you also agree with this. I don't know exactly what would be your option after your data in front of a very young patient with, let's say, a single bone metastasis, 50 years old, healthy man. You know, these data, I fully agree with you that they are retrospective with very low power, statistical power. But you have this patient and you've gone through your own trial, that you know your pathological results that I was going to ask you later. what would you do with that patient, particular patient?
So I would either offer him radiation to the prostate, or if I think about surgery, I would only offer it within a clinical trial, and we are going to participate in the next Stampede arm, which will have the opportunity to include patients with metastatic disease who will receive surgery. So, yeah.
Okay. So you fully agree with the guidelines to stay on trials? No,
I'm on the panel, so I agree.
But you really know that, and I can tell you for sure, that I've been trying very hard to get involved in one of those international trials for metastatic prostate cancer, and it's not so easy if you don't work in Martini Clinic. So let's say you work in Valencia with me, what would you do to that patient? You don't have option to get into the Stampede arm SETA.
Yeah. I mean, I agree with you that it's difficult, and there are individual cases where you are really not sure. We also, in our experience, we even had patients who were classified as metastatic, and in the end, it was not a metastasis. And these patients clearly profited from the surgery. And so, in these individual cases, I agree, it's difficult. And also, I don't know the situation in Spain, but I believe it's difficult to get the randomized trials.
That's my own experience, as I will tell you later. And in case you recommended radiotherapy to the primary tumor in patients with newly diagnosed low volume burden metastatic castration-sensitive naive prostate cancer, who also have clinical pelvic N1 disease, do you recommend radiation just for the prostate or prostate and pelvic lymph nodes?
So I would also do number one, because patients with bone mets, they often have microscopic, at least, disease at the lymph nodes too, and I don't think that adds much morbidity, so we would also include that.
And also you have data coming from SMP that supports this combined radiation. So, few words in Spanish. Ahora había unos casos clínicos, pero me pareció, como yo había preparado nuestra modesta casuística en esto del IVO, pues no he traído, y pido disculpas a los que estaban en la mesa, pero voy a centrarme en nuestra propia experiencia para justificar lo que es el día a día con estos pacientes, la posibilidad de ofertar algún tratamiento. Por lo tanto, como son colegas de aquí, creo que me van a entender que vamos a centrarnos en la Martini Clinic. So, this is our local, in Ivo, in my institution, casuistic with a very modest experience, but I've seen a publication in European Urology with 11 patients coming from Milan, of course, right? So we have 2 more, so we are, I think, a little bit allowed to talk about this. As you can see, our 13 cases, they have a mean age of 65, a median PSA of 68, and a mean PSA of 53 and a median of, that's first thing I would like to point out. Median PSA in the HORA trial was 150. In the Stampede data was 97. In our series, it's because they are selected cases, that the one I presented to you is 53. So I think, as with the data you have presented of potential beneficial, we would be close to that threshold, more or less. Okay, so I keep going. Most of them are Gleason 4 or 5, and most of them are local advanced with Charlson score, okay, good for local treatment. And I would like to stress that all of them, not all, there were 2 cases, one with one case with 6 metastases, one case with 7 metastases, and these were locally treated because local symptoms. That's another story. And the rest of them, 11, were 10 with just 1 metastasis and 1 with 3 metastases. Another important thing that I wanted to ask you, in your RAMP study that you have recently closed, did you have all the patients studied with PSMA? No, just conventional imaging?
Both. It was both allowed. So however they came in, if they had an outside PSMA PET, that was fine too. If they had a bone scan, also.
So this will be a very great stratifying factor in the results of that trial, and I would like to have those data, because we all put our 13 cases. We have no PSMA at Spain, and we have just some cases with pelvic resonance. On some of them, maybe our whole gland, but 100%, the 13 cases were staged just with CT and bone scan. And all had hormonotherapy as first line, okay? And this is my second question. Some authors, they have pointed out that you need to, for example, your Heidenreich, he stated that you have to give some period of hormones, and together with the hormonal trials, historic hormonal trials, if you get a PSA nadir after 3 months, let's say, of hormones of below 0.1, then you are allowed to do local treatment. If you don't get that, you are not allowed to. And this is a pitfall of Heidenreich's study, because in the control arm of him, he has some of them that they didn't dropped down that level. So the comparison arm was not the good one, was not a pure one, right? Do you think that's a trigger point or a surrogate endpoint to do or not to do local treatment?
So yeah, you are talking about the Journal of Urology study of Axel Heidenreich. So he, indeed, that's a great example of selection bias. He selected for the really good patients who responded to ADT very well, and those patients received surgery. In our study, that was not a point regarded.
Okay.
The response to ADT. So.
Okay, so in our own experience, I don't know if, because what Bernard Tombal once told me, it's like the one wagon effect. Is everybody do this, I will do this. But the thing is that we did these 13 cases, most of them with single bone scans, bone mets. Of course, the charted, both the charted and the latitude criteria were very similar and were very low volume or low risk with latitude. And another fact that we don't find in those SEER paper or those big data centers data is the things that they do after the local treatment. Which treatments, which strategies, and I would like to stress out that this is a very simple case series, but you can see there how many treatments these patients get after the local treatment. Like, say, for example, radiotherapy, rescue radiotherapy or radiotherapy in the bones for SBRT or whatever. It's very common. Hormonotherapy, not in all of the patients after the local treatment, so we will come back for this. And we just did 4 radical prostatectomies. Okay. So our follow-up is very short, and if you find a follow-up of less than 50 months in a prostate cancer series, you think it's short, but for metastatic prostate cancer, maybe it's not so short, right? We have to change to a metastatic setting, metastatic scenario. but our median follow-up was 28 months. And with this, honestly, short follow-up, but I don't know if it is valuable or not, we have 6 patients that we consider they are free of disease. And I say I consider they are free of disease because I'm not quite sure about that. Because maybe, as she has pointed out, within these 13 patients, some of them were not real metastatic. But CT and bone scan are not perfect. You know, they are not perfect. So this is a mix of patients that it's difficult to it. And these are our results. This is free of disease after local treatment, 4 cases. This is progressive disease after local treatment, another 4 patients. This is progressive disease after local treatment and treatment of the oligometastatic sites, 3 patients. This is free of disease after local treatment and treatment of the oligometastatic, 2 more. So this is not fair. I think with 13 cases we cannot do, but we are in a friendly atmosphere, and I have asked my aestheticians to work these graphics out, and we have 3 patients that have died. But maybe more important with that follow-up is an endpoint, which is clearly a surrogate point for prostate death, which is time to castration resistant. And we have 9 patients out of 13 that have not reached this stage yet, and 4 that have converted to prostate cancer resistant cancer. So I know it's not fair to draw these lines here, but at 3 years, we would obtain a projected disease castration resistance-free survival of about 83%. Do you think this is the normal percentage of a metastatic prostate cancer to become resistant to castration?
Yeah, so since it's really low numbers, you select them very, very carefully, and most of them had 1 metastasis, so I would find this a typical percentages because they are highly selected, but not you cannot extrapolate to the general.
We don't want to extrapolate anything here, but we are very cautious about that. But these patients, they do exist, and sometimes they are. I think I distinguish two patients. The young one wants to fight everything, try everything, and you are not sure about what you've read. You have all the doubts you have, and you have elegantly demonstrated that all those data are very flawed. But at the same time, you have these results that are somehow comparable to those flawed data, right? And after local treatment and after local treatment of oligometastatic sites, this is second progression of metastasis-free survival, okay? So we have 6 cases that have gone through it, but 7 no. And this gives a 3 years disease-free progression, metastatic progression-free survival of about 77%, which is, from my point of view, in a metastatic setting, a valuable data. Although it is, and I repeat, these are 13 cases. And I asked my aesthetician, let's see if some of these patients are free of hormones, because they were classified as metastatic at the beginning, so all of them were with hormones. But in the follow-up, let's say because we were wrong in the staging, that's a possibility, or because treatment of local treatment plus treatment of the oligometastatic sites have been successful. We have 6 cases that are not taking hormones for any reason, and they still with low PSA. I can show you the 6 PSAs are below 1. So those are our honest data in this case. I think they are very mixed, and it has been difficult to summarize them. But I would like also to ask you, because probably you know that the trombone English trial has been recently closed, I think, or
yeah. So we were part of trombone, so I've operated on 4 patients within trombone. Taking from it, it was by far best to give the systemic therapy first. The radical prostatectomies are much easier, shrinks the tumor, makes the surgery easier.
coming back to my first question to her,
Yeah.
do you get any PSA level that allows you to go?
So that wasn't part of trombone, and in fact, they didn't even say whether you go for systemic therapy first or not. It was up to the clinician or the patient. I did one without systemic therapy, and that was, I don't like to cut through tumor. So, I mean, we selected one patient very badly who didn't have resectable disease. I mean, I think they need to have resectable disease. So we didn't have any preconceived ideas about systemic therapy, but we now think if you're going to do it, you should give it first. We didn't have any complications. They were just like a normal patient group. I mean, the big problem we have is we have a lot of PSMA PET, and so we keep finding tiny little hot spots in patients that we wanted to operate on, and PET just causes lots of problems. It's not necessarily the solution. In fact, sometimes I wish we didn't have PET because I'd be able to operate on this young guy. And you're not.
So what was the staging workup for the trial?
For the trial, so it was just standard of care, whatever was standard of care in your institution. So we did do PETs, but other centers just did bone scans. So that's one of the trombone was just to look at feasibility of whether patients were happy to be randomized. And we found no problems with randomization. Patients were more than happy to be randomized into surgery versus systemic therapy.
And do you have any data? I think you can. If you have, maybe you cannot give us, but maybe of local complications of the RAM trial, because you have said no word about the local control of the tumor. This is the always forbidden endpoint in every oncological trial. But this is clearly in favor of local treatment against no treatment.
So
I think.
yes, this argument is always, I shortened my talk a little bit, so I have it in one of my talks, that it's local control, but in reality, in metastatic disease, most of the patients die before even local complications can occur. There have been different studies showing that. It's the minority of patients which get local complications at metastasis before dying. So, with regards to local complications, and we don't have it in the GRAMP, but we had a pilot trial, PROMPT trial, where we had those numbers, and there were maybe 10% of patients with local complications. So the majority didn't have local complications.
Bueno, ¿alguna pregunta de la sala para la doctora? Yo creo que es un lujo tener aquí a alguien de la